Well, let's talk all about the reconceptualization of the new category of feeding and eating disorders in the DSM-5. The truth of the matter is, this reconfiguration represents a sea change in revision in this category within the DSM. Why? Because number one, it changes the number of different disorders that are in that category and adds new ones. Two, it actually combines together two previously independent groups, the feeding disorders of infancy and early childhood, and the adult, if you will, and adolescent eating disorders of anorexia and bulimia. It adds in new disorders, and it changes the criteria for other disorders. So all in all, it's a very substantial change in this category, arguably the single biggest change since the introduction of the very first DSM in 1952. So let's talk some of them then again about what we're going to be addressing over the period of this next hour. First of all, we're going to talk some about the development of the eating disorders in the Diagnostics and Statistics Manual across time, so we can get a better sense of where we have come from, where we're at now, and in all probability, where we are likely to be heading toward. Number two, we'll talk about 5 significant changes in the overall psychiatric nosology of the DSM-5, the entire categorical system, because these are ones that have direct implications and consequences for this section on the feeding and eating disorders. Number 3, we're going to talk about feeding and eating disorders themselves in some detail, detailing each of the disorders that are officially credentialed at this time within the DSM-5. And then we're going to talk a bit about current controversies and future directions, and then conclude with a summary of what we've talked a bit about. Well, let's go ahead and get started. Let's talk about the development of eating disorders in the DSM-5 and the history that supports this contemporary development. Probably the best place to begin in relation to this is to understand that the DSM is now and always has been a derivative document. By that I mean it is derived from the larger categorical system that is known as the International Classification of Diseases, or the ICD, that is owned and operated by the World Health Organization under the auspices of the United Nations. United Nations version of the World Health Organization's ICD has a history that dates way back into the 1850s. By comparison, the DSM is relatively recent. It's very important to keep in mind that the International Classification of Diseases, the ICD, actually includes every kind of disorder or disease you could possibly get across all systems of disease. So for example, here you can see this is a sample of the most current version of the ICD ICD-10-CM for clinical modification that's used in the United States. And you can see that these are the chapter headings. There are a few things I want to point out to you. Number one is you can see that the chapters are organized by sort of systems unit. So for example, there's a chapter on infectious and parasitic diseases, another one under endocrinological diseases, respiratory diseases, and so forth. So each chapter is organized by sort of a medical or biological system. Keep in mind, I'm showing you here only the first 10 of a total of 21 chapters. The point is that the ICD, unlike the DSM, contains every kind of health problem you can possibly get, from sort of soup to nuts. Now, the second thing I want you to notice is in Chapter 5, it's a chapter called Mental and Behavioral Disorders. Mental and Behavioral Disorders is one chapter and only one chapter, and it turns out that it is the chapter that the DSM is patterned after and derived from. It is quite literally the case that post-World War II, when literally millions of people were being disgorged from the front line of battle across all nations basically on the planet, they were being returned to pre-printing press era kind of psychiatric diagnosis. There was no commonly agreed upon psychiatric nosological system. This was in the late 1940s. So people didn't agree. People didn't agree within a country, they didn't agree across country, and we needed a common nomenclature. At that time, the World Health Organization credentialed a common system. They included it as this Chapter 5. It was then known as Mental and Nervous Diseases. It's now known as Mental and Behavioral Disorders. However, the ICD was then and is to this day a coding manual and not a diagnostic manual. What do I mean by that? What I mean is this. In every single disorder, whether it is a common cold, a broken leg, a myocardial infarction, or an endocrinological disease, the ICD carries a title for that disorder. It carries a number so that it can be coded in healthcare records, and it contains a couple of sentence description of that disorder. It does not contain diagnostic criteria per se. In other words, it does not enable you to determine how best to diagnose a disorder. In medicine, they sort of assume that you know how to diagnose a disorder. That's why you went to medical school. So the ICD doesn't tell you how to diagnose a myocardial infarction. Your training to become an MD does that. However, the American Psychiatric Association, at the time of the introduction in 1948 of these mental and behavioral disorders into ICD, they came onto the picture and they recognized the huge advantage of developing a full-blown diagnostic system, not just a coding system, but a diagnostic system for these mental disorders that there was no current sort of common agreed upon nomenclature for. So they quite literally went to the World Health Organization, they knocked on the door in Geneva, and they introduced themselves as the American Psychiatric Association with a simple request. We would like to borrow your F codes. Notice Chapter 5 carries codes that are all F codes, F00 through F99. All the mental and behavioral disorders are F codes. World Health Organization agreed to allow the American Psychiatric Association to borrow those codes under the provision that they recognize that those codes always belong to the ICD and not to the DSM. The DSM does not own those codes, they only borrow them. They actually just are sort of like their children. They invited them to come out and play. They agreed to nourish them. They agreed to care for them. They agreed to help facilitate their growth and development into a full-blown diagnostic manual. But the ICD still retains proprietary control over those codes. That's why the DSM is a wholly derivative document. The DSM-5 is in fact a blown-up version of the ICD Chapter 5. ICD Chapter 5 is the DSM-5. Every code in the DSM-5 is in fact an ICD code. It is the only officially recognized nomenclature in the United States, federally recognized codes. So I just want you to be aware that the DSM, including the DSM-5, is a derivative document of the ICD, and it contains basically a blown-up diagnostic version of the coding that is contained in one and only one of the chapters of the ICD, Chapter 5, Mental and Behavioral Disorders. So I mentioned that the ICD introduced mental and behavioral disorders in 1948, just after World War II. The DSM got permission to borrow those codes, to blow them up into a diagnostic, full-blown diagnostic system with criteria, enabling people to become more reliable, greater reliability in psychiatric diagnosis, greater agreement in what constitutes a given disorder. And they came out with their first version of the DSM in 1952, on the heels of the introduction of the behavioral and mental disorders in the ICD. It's important for our purposes to recognize that the DSM-1, from its very inception, contained an eating disorder. The first eating disorder officially recognized there from the beginning in the ICD, in the DSM, was anorexia, A-N, anorexia. Anorexia was recognized in the DSM-1, but of course the DSM-1 was a primarily psychoanalytic document because in the 1950s the prevailing conceptualization was a psychoanalytic conceptualization. So the conceptualization of anorexia seems very primitive, very odd, very queer, very much like an atavistic throwback to an earlier era. The analytic notion, for example, that anorexia is a woman's fear of oral impregnation really sounds tinny on today's ears. It almost sounds offensive. It seems such a sort of atavistic throwback to an earlier era. So I want to just mention that while it was a recognized credentialed disorder and has that time-honored recognition, it also is the case that the conceptualization of what constitutes it has changed dramatically across time. DSM-2 is introduced in 1968. It becomes a little bit more behavioral because remember, we're now moving from a psychodynamic or first world order kind of conceptualization. The sort of first force psychology is regarded as psychoanalytic, to that sort of second force. Second force is commonly regarded as behavioral. So if you read the DSM-2, you'll see that it is couching now its terms and its descriptions of disorders partially in behavioral terms and partially in psychodynamic terms. It's kind of an incipient stage betwixt and between those two forces of psychology, analytic and behavioral. But they didn't introduce any new behavioral disorders in the feeding or eating disorders, and that didn't happen until DSM-3 came along in 1980, and there we had the introduction of the second eating disorder called bulimia or bulimia nervosa, the second inclusion of a formerly recognized credentialed eating disorder. Well, the DSM-3 gets revised, and DSM-3R for revised in 1987. It is in fact a substantial revision, not a minor revision of the DSM. However, it did not articulate with an ICD revision. Remember, the DSM is a derivative product of the ICD, and one of the things they had to promise is that they would never come up with a brand new edition of the DSM unless there was a new edition of the ICD to accompany it. In other words, the ICD would never allow itself to be scooped by the DSM. For that reason, the DSM-3R had to call itself a revised version of the third DSM and not DSM-4. They had to wait until 1994 to come out with that fourth edition, at which point they introduced the third recognized behavioral disorder in the eating disorder category, but they only included it in the conditions of further study. In other words, it's sort of put in purgatory for almost a 20-year period of time. It was under further study to see whether or not it should or could gain ascendancy into formal and full recognition. And so its inclusion as a provisional diagnosis worthy of further study happened in 1994. The DSM-4 got revised, but only a text revision, the DSM-4-TR. There were no new disorders included, so binge eating disorder had to sit it out. It's like it had to sit out another quarter of play. In this case, it had to sit out almost a 15-year period of time in this sort of purgatory, holding on because no new disorders were allowed to be included in the DSM-4 text revision, only infusing the DSM-4 with the latest and greatest scientific knowledge that had transpired since the publication of the earlier version, DSM-4, in 1994. So we had to wait then until the most recent edition of the DSM, the DSM-5, at which point binge eating disorder could be brought up out of the appendix, the conditions for further study, given its own formal recognition and credential, and given its own code. And that's where we stand at this point. We have we have three fully credentialed disorders on what was once the adult side: anorexia, bulimia, binge eating disorder. And then we're going to talk about the feeding disorders that join them as well in the new category in the DSM-5. Disorders of feeding and eating disorders. Well, let's talk about 5 overall challenges or changes that have occurred in the DSM-5 that impact the diagnosis of eating disorders themselves. And here I want to mention first and foremost why it is that the DSM-5 is the DSM-5 and not 5. Notice that DSM-1, 2, 3, 4, 3R, 4R, all were in Roman and not Arabic numerals. This is the first time we see the DSM-5 using Arabic numerals. The DSM-5 is the DSM-5 and not the DSM-5. Well, why is that? Well, the simple reason is this. The truth of the matter is the half-life of knowledge in professional psychology is becoming progressively shorter and shorter and shorter. By that I mean that the dissemination of knowledge and the production and generation of knowledge is happening at an increasingly rapid pace, which means that our knowledge becomes obsolete more and more and more quickly. And as you could see in the revisions between the various editions of the DSM, starting in 1952 on through the most recent version launched in 2013, you can see that there's 10 to 15 years between the new editions of the DSM. Knowledge generation happens too quickly to permit that kind of revision occurring in what amounts to basically geological time. So the DSM-5 made the decision that we were going to have from this point forward more rapid opportunities for the infusion of new knowledge. So we're going to introduce the concept of micro revisions. In other words, just like your software program, say a Microsoft 2.1, soon is going to become 2.2, 2.3, 2.4. The same is true here. The DSM-5 will soon become a DSM 5.1, 5.2, and so forth. Nobody knows how often those micro revisions will occur, and nobody knows how frequently they will occur or how many there will be. But there will be micro revisions which give an opportunity to infuse the manual with the latest and greatest knowledge, but not necessarily with new disorders per se. It was important that they move over to Arabic numbers from Roman numerals because otherwise a DSM 5.1 would look like this, very much like a DSM-6. If it were in Roman numerals, a 5.1 is going to look like a 6. So you had to move over to Arabic numerals where you can read very clearly and cleanly a 5.1. Moreover, looking forward, the DSM recognized that by the time we move down the road and we have things like a DSM 9.9 or a DSM 6.6 or whatever it may be, in Roman numerals, those are going to be increasingly difficult to decipher iterations. Ergo, let's move over to the kindler, simpler, gentler Arabic numerals that we are all comfortable with, and that's what we'll be using from this point on. You will never see another Roman numeral. You will have lived past the day of Roman numerals in the DSM. The other thing, second thing I want to mention is the discontinuation of the multi-axial system that the DSM-5 introduces. Well, why did it do away with the DSM's time-honored tradition for having multi-axial diagnoses? Multi-axial diagnoses were introduced way back in DSM-3 in 1980, so they had 33 years of a history with multi-axial diagnosis. Why do away with it in 5? Well, they did away with it for two reasons. Number one, and they're closely related reasons. Number one, they wanted the DSM to articulate with a medical nosological system. Okay? The medical nosological system, as you could see, is the ICD. That covers all the health systems, everything you can get, everything you can die from, every disease and every cause of death. Disease is morbidity and death is mortality. So ICD covers all morbidity and all mortality. In order for the DSM to have the same look and feel of what the doctors use, then it too needs to become a uniaxial system. The ICD is not multi-axial, so the DSM is trying to pattern itself after so that it has the look and feel of the ICD. That's important because the DSM is designed increasingly to harmonize with the ICD. That is, for the two of them to be used seamlessly together. We can see that very clearly in the DSM because you can see now the DSM literally uses the codes from the ICD. So the two doesn't make sense to have two widely divergent different nosological systems. Let's make them blend, let's make them match, let's make them articulate, let's make them harmonize. And that's exactly what the DSM-5 is trying to do. And the biggest single step you can take in that direction is to do away with the multi-axial system and make it uniaxial just like the ICD. Now, the particular dimensions themselves in the multi-axial system that were in the DSM-3, 3R, 4, and 4TR were these here. Clinical syndromes, the mental retardation and personality disorders was axis 2, 3 was general medical conditions, 4 psychosocial problems, and 5 was general or global adaptive functioning. Well, what happened? Now, at this point, every single disorder, including all of the eating disorders, are functionally on axis 1. There is only one axis. Axis 2, the old mental retardation and personality disorders, got done away with for a number of reasons. Some of them have to do with the fact that people were not always on board with personality disorders. For many people, it feels as if personality disorders are a throwback to an earlier era, almost the analytic tradition of character disorders. And so some people didn't actually believe in the existence of personality disorders. On the other hand, many people believed in the existence of personality disorders, but they thought, gosh, they feel awfully pejorative. It feels to me as if when I diagnose somebody with a histrionic personality disorder or a borderline personality disorder, I'm diagnosing them not for what they have, but for sort of who they are. So some people were reluctant to confer personality disorder diagnoses. Third, and perhaps most importantly, prior to healthcare reform in the United States, there was something called a pre-existing condition. A pre-existing condition is something that you had before you got your insurance policy. And for that reason, it was excluded from coverage. You could not be paid or reimbursed for something you had before you got your policy. Many people, not all people, but many people would get their first insurance policy in their mid-20s or late 20s after they graduated from college and got their sort of first career kind of job. The problem is personality disorders, by definition, must be present by the age of 18 with indications of that disorder prior to that time, which means that by definition, they became pre-existing conditions. In other words, not regularly or routinely reimbursable by many insurance companies. So what did psychologists and psychiatrists and others quickly learn to do? They quickly learned to put them in not as primary conditions, but secondary conditions. So it's very, very, very common that personality disorders would be diagnosed over 90% of the time, not as a primary concern that the person would be getting insurance reimbursement from, but rather a secondary condition that was sort of the backdrop that would get treated after the primary. So you'd have a dependent personality disorder, but with unipolar depression. So you would diagnose depression first, and you would get reimbursed for depression, and then there was this underlying personality disorder of, say, a dependent personality disorder. So it really wasn't fulfilling its promise because people weren't really using it, or perhaps using it properly. So out with Axis 2. Axis 3 had to do with general medical conditions. General medical conditions was designed to allow us to indicate physical disorders, medical disorders that accompanied psychological disorders. Somebody comes into you and they have a generalized anxiety disorder, they have a depression, they have a phobic disorder, whatever they may have. And they also have medical conditions. So for example, they may have a mitral valve prolapse, or they may have an ulcerative colitis. It allows you to see and you to record the physical disorders that may accompany, say, an anxiety disorder. Well, why would you do away with something as helpful as coding for general medical conditions? Well, when the DSM-5 was launched in San Francisco in 2013, we asked that of the chair and vice chair of the DSM-5, David Kupfer and Daryl Regier. And the response was, we had to do with general medical conditions because we're trying to make the DSM a general medical document, a medical document. It is, after all, produced by the American Psychiatric Association, which is a part of the American Medical Association. So we can't have an axis that says general medical conditions, because in the DSM-5, we regard everything that somebody has as a general medical condition. And so we can't have something called general medical conditions because it implies that all those psychological disorders are not general medical conditions. So in the DSM-5, whether you have an exploding appendix or an exploding ego, you are suffering from a general medical condition. Ergo, if your eye offends you, pluck it out. General medical conditions had to go. 4, psychosocial problems. Psychosocial problems in all the earlier DSMs was a checklist of things that helped contextualize the disorder you may have. That could be something like problems with housing. Maybe the person was homeless. Maybe the person was systems implicated. Maybe they're in a substance abusing kind of context. Maybe they didn't have access to health care insurance. These would be all things that would be expected to contextualize and maybe even exacerbate the psychological problems or disorders. So you would make note of that. Why would they do away with something so incredibly important as that? Since we all know that context is king. If you have somebody coming into you and they have a depressive disorder and they are insured and they are middle class and they have a nice job, that's actually quite different than somebody who's coming into you uninsured, jobless, and homeless. So we all understand context is king. Why would you do away with Axis 4, psychosocial problems? Well, in a nutshell, the reason you do away with them is because they are not essential to the diagnosis of a disorder. When we asked this of the chair and vice chair of the DSM-5 task force, what they said is, we're not saying that psychosocial context isn't important for understanding and treating disorders. However, what we're saying is they're not essential to the diagnosis itself. So, for example, we know with a heart attack, a myocardial infarction, you can come to that disorder in lots of different ways, lots of different causes. You could have a hereditary predisposition. You can have poor diet and exercise. You can have a high-stress job. You could be a type A personality. Any or all of those might load into you becoming or being vulnerable to a heart attack or myocardial infarction. But myocardial infarction is a myocardial infarction no matter how you get it. Etiology and intervention don't define what it is you have. Etiology is about how you get it. Intervention is what you do about it, but it is what it is regardless of how you come by it and regardless about what you do with it. So out with Axis 4, psychosocial problems. Axis 5 was global adaptive functioning, and that was just a simple score, a single score from 0 to 100, indicating your overall level of functioning or capacity. Global adaptive functioning. A 0 would be somebody who had sort of was a mass of psychological putridity, melted down into a state of complete decompensation, and 100 would be almost like a Maslowian self-actualized person. There were many problems with the global adaptive functioning scale. One of them was, of course, that it really was never a 100-point scale. The truth of the matter is, I've never seen a 10, I've never seen a 20, maybe I've seen a 30 in the back wards of some VA medical centers, but most people are sort of in that 40 up range. On the high end, I've yet to ever see 100, I'm not sure I've seen 90s, I'm not sure that I myself have ever been an 80 in anything more than a 2 consecutive week period. Most of us live our lives in that sort of 60, 70 plus sort of range. So it was really a truncated scale. It wasn't a 100-point scale, but more importantly, it confabulated 3 dimensions, because the rating that you would give somebody would be determined by 3 things: their level of suicidality on the low end of the scale, severity of symptomatology, and their overall overall level of disability or dysfunction. Put aside suicidality, that obviously is a horse of a different color. Consider only level of symptomatology and degree of disability. Isn't it fair to say that level of disability and degree of symptomatology are neither the same thing, nor are they completely independent from one another? They're not isomorphic, but they're also not orthogonal dimensions. Isn't it fair to say that you've seen many people with very severe pathology, very severe symptomatology, that were not disabled? There's a fellow, Frederick Fries. He's a paranoid schizophrenic, high levels of symptomatology, and he was for over 30 years the head of the Ohio Community Mental Health System. So there's high severity of symptomatology, low levels of disability. And isn't it true you've seen the obverse of that too? People with fairly minor symptoms that were utterly disabled by them. You would recognize that if you've ever worked in a pain clinic. 2 people have the identical level of pain. The symptoms are of the same severity, but one is highly disabled. The other pulls himself up by the bootstraps, goes to work, gets the kids breakfast, gets them to school, does everything it needs to do to function during the day. So what would the DSM have asked us to do before in conferring a global adaptive rating on individuals in diagnosis? Well, they would ask you to give the person whichever was the lower of the 2 ratings. So if somebody comes in with a 70 on disability and say a 40 on severity of symptomatology, you would give them the lower of the 2. You give them the 30. How about if they came in the other way around? What if their level of disability was 70 and the severity of symptomatology was way down at a 30? Which would you give them? Again, you give them the lower. You give them the 30. So then I ask you, what does the 30 mean? Does it mean level of severity of symptoms, or does it mean the degree of disability? And the answer is yes, it means both. So something, anything that means many things, ultimately means no thing. Ergo, axis 5, it goes out the window, global adaptive functioning. We're in now a uniaxial system in the DSM-5. The third thing I want to mention that contextualizes the eating and feeding disorders category is that the DSM now is much more of a biomedical kind of document. It's designed to follow the contours of neurobiological advances. Here is a quote from the DSM-5, and what it's doing is it's saying, you know, we don't have a thoroughgoing neurobiological understanding for all of the 300 and some, nearly 400 disorders in the DSM, but we're going to have to, in this incipient stage between now and when we come to understand the neurobiological understanding or etiology, we're going to have to just accept the fact that we're going to have to rely on the clinical utility of the document. So they say, quite literally, until incontrovertible etiological or pathophysiological mechanisms are identified to fully validate specific disorders or disorder spectra, that is, combinations of disorders, the most important standard for the DSM-5 criteria is going to be their clinical utility. Okay? And then gradually we're going to replace the mere usefulness of it with actual studies of validity, that is, that help underscore the neurobiological causes of the various disorders. So they're basically serving notice that the DSM-5 is going to continue to shift and change and morph and develop as our neurobiological understandings continue to do likewise. At the American Psychiatric Association convention, when they launched the DSM-5, there was a cute little joke that was going around, and it was just underscoring the neurobiological orientation of the DSM-5. And there was, in this joke, a neurologist talking to a psychiatrist, and the neurologist says, "We treat the axon and you treat the synapse." It's this notion that the orientation is a thoroughly psychobiological one. A neurologist deals with the sort of hardwiring of the system, the neurobiological system, and the psychiatrist treats that sort of neurochemical gap primarily with psychopharmacology. So I just want to mention that it's much more of a neurobiological document. It is because the DSM's position became one of we are going to have to do this, rely on clinical utility until we can understand all the underlying biological causes. We're going to have to sort of suspend our notions of validity until science catches up with us. It's for that reason that the National Institutes of Mental Health decided that they would put a pause on robust funding of grants that were predicated on DSM-5 diagnoses. Why? Because you can't spend billions and billions and billions of public dollars on kind of phantom disorders, that is made up disorders, disorders that rely on clinical utility and don't have demonstrated validity. So the jury is now out in relation to that. One of the major concerns, the fourth of the five contextual things I want to call attention to, was the mission creep in the DSM-5. By mission creep, I mean the tendency of the DSM-5 to admit more and more and more disorders into the category of mental illness, adding more people into psychodiagnosis. This has caused a very, very significant concern. It was a significant concern of both Bob Spitzer and Al Francis. They were the task force chair of the DSM-4, DSM-4 TR, 5 and 5, DSM-4, DSM-3, 3R, 4, and 4TR, so the four successive previous versions of the DSM. And both Spitzer and particularly Al Francis waged what could fairly be described as a scorched earth campaign against the DSM-5 because of its tendency to pathologize and have a voracious appetite for pathologizing powerful and negative but normal human experience. Alan Francis had the famous sort of warning or caveat: if this version of the DSM is issued unamended by the American Psychiatric Association, it will medicalize normality and result in a glut of unnecessary and harmful drug prescription. This is his position. So adamantly and vehemently did he hold the position that he wrote, as you may know, the book called Saving Normal, because he believes that we have jeopardized that normality in the DSM-5. Well, the DSM-5 has experienced, in truth, a variety of forms of mission creep, and those forms of mission creep are central to the category of feeding and eating disorders. Now, it engages in the mission creep in a couple of very characteristic and normative ways, and a couple ways that are kind of unique and special to it. Number one is it adds new eating disorders. Every time you add in more disorders, you increase the number of cases of mental disorders that you diagnose. So in the case of eating and feeding disorders, we know we have some renamed disorders, but we also have the first inclusion of the binge eating disorder. So you're naturally going to be tossing more into this category. Second way that you can add disorders or make higher rates of mental illness in psychodiagnosis is to relax the criteria. Every time you take criteria and you make them more stringent, you push people out of the category of mental illness. Every time you relax those standards, you bring more people into the fold. Well, the truth of the matter is the vast majority of the changes in the criteria for DSM-5 mental disorders are to relax those criteria, not to make them more stringent, but to make them more lax. That's true as well as we will see in the category of feeding and eating disorders. A third way that you enhance the DSM-5's, if you will, voracious appetite for pathologizing powerful and negative but normal human experience is that you create an appendix runaround, an end around. It used to be in DSM-3, 3R, 4, and 4TR, the only way you could get into the document was to land first in the conditions of further study. And you would sort of languish in there while research built up that either favored or disfavored your official inclusion in a subsequent version of the DSM. Well, in this case, in the DSM-5, for the first time, disorders were brought in as an end around without first going through that category of conditions of further study. They were brought in for ideological reasons and not for empirical reasons. This is why many people regard the DSM-5 more as an ideological than an empirical document. I think that's only a half fair characterization. This doesn't apply directly to the category of feeding and eating disorders. There was nothing that was brought in as sort of an end around the conditions of further study. In fact, as we saw, binge eating disorder languished for a couple of decades in the category of conditions of further study until it was included just in 2013. So these are the various ways that you can get in. You could also be brought in by inclusion, unofficially, informally, inclusion in that category of new conditions for further study. There are no new eating disorders in that category under consideration at this time, somewhat contentiously, because one of the major contentions in the previous version of the DSM was whether or not we would honor or credential or condone compulsive overeating. That one did not resurface with the same vehemence this time that it did last time, but it is not included as a condition for further study in the DSM-5 at this time. The fifth thing I'll just mention is the classification, reclassification, and recombination of the disorders in the DSM-5. It's really a sea change in reorganization over the relatively consistent categorization of DSM-3, 3R, 4, and 4TR5 now really shakes up everything and redistributes them. It's almost like reshuffling a deck of cards and dealing it out in very different order. I'm just going to show you the table of contents, starting with neurodevelopmental disorders. It should not be lost on you now, knowing that the DSM-5 is organized around neurobiology, that the very first condition in the very first chapter, in the very first syllable of the very first word, you will find neuro. That is not by default. That is, in fact, by design. It is advertised in the neurobiological orientation of the DSM-5. You can see the other disorders going down. This is by chapter, and I just want to call attention to the chapter I have listed here is K, that is feeding and eating disorders, and this does represent the combination of two very different disorders. In all previous DSMs, there was a disorders of feeding in infancy and early childhood, and then way back in the book under the adult disorders was, and that was always the first chapter, chapter number 1. It's been replaced by the neurodevelopmental disorders. There are no childhood disorders per se, no childhood chapters in the DSM-5. So feeding and of disorders of infancy and childhood was at the very first chapter of previous DSMs. It's now been joined to the eating disorders that's always been further in the back of the book. So it's now a combined feeding and eating disorder. So it's pretty dramatically enhanced or increased in size over what it was previously. Combining those two and inviting some developmental opportunities as well as challenges. These are just some of the remaining chapters in the DSM-5. Well, let's turn to look at the feeding and eating disorders themselves in greater detail. First of all, I want to call attention to the fact that there are a lot of developmental features in feeding that are worth calling attention to. A developmental perspective on eating disorders really includes sort of a cradle to the grave kind of understanding about eating and problems that can arise in relation to it. And now that the two are combined, the feeding and eating disorders, those things that were in infancy all the way up to those in adulthood, now that they're joined together, maybe there will be more attention to lifespan transition, not just what happens down here and what happens up here, but the bridge that joins the two together. Of course, joining them together creates some challenges as well as some opportunity. The challenges, just as a simple example, is that many of the criteria that are applicable to the adult disorders require kind of capacity for cognition and abstraction and social awareness that you really couldn't expect in a child. So, for example, if you consider all the concerns about body image distortion in, for example, bulimia or anorexia, it's really not reasonable to expect that an infant has tremendous body image distortion. That is, they feel fat when they're not, or they perceive themselves as overweight when they are not. They don't have that kind of awareness. It's not reasonable to think that they have that kind of capacity to decenter and see themselves in an objectified way, in the way that you might once you reach adolescence or certainly adulthood. So some of the criteria that are key to some of the adult eating disorders clearly are not going to be appropriate for the childhood disorders. So we have to take a kind of careful look at making the standards developmentally appropriate or developmentally contingent. Of course, there are opportunities I mentioned, and that is combining the feeding disorders and the adult bulimia, anorexia, and now binge eating disorder in together may invite us to spend more time on looking at and critically examining the bridge that joins the two together. Well, what are some of the developmental tasks related to feeding? I want to call your attention to this because they are critical not only to the development of feeding behaviors, but also to the sense of self and to, in some ways, the adhesion to culture and society and participation in our families. It's not just about nutrition. It's not just about biology. Feeding and tasks having to do with feeding, developmental challenges, actually permeate all levels of social participation. Let me tell you what I mean. So, for example, how is it that you learn to select appropriate kinds of foods? How do you learn what it is that you can eat and can't eat, what you should eat and shouldn't eat. That's a process of learning that unfolds across time. How about the physical handling of food? You've got all kinds of developmental challenges about, do you eat with your hands? Some foods we eat with our hands, some we don't. You have to wash your hands before, and you have to wash your hands as you eat. You have to clean your hands after you eat. There's the physical handling of food and refrigerating. These are fairly complex kind of tasks that we have to learn about in relation to food handling, preparation, ingestion, and so forth. Relatedly, food hygiene. And food hygiene varies widely, as you know, culturally, socioeconomically. Many of us have the 10-second rule. Piece of food drops on the floor. If it's not there for 10 seconds, boom, you can eat it. But longer than that, the germs will have had it. So these are all culturally mediated constructions. Sensory integration. By that I mean foods have textures, foods have flavor, foods have temperature. You could have a chewy, warm food. You could have a crisp, hard, cold food. Kids have to learn to deal with this wide variety of temperatures, textures, flavors, and so forth. It's not a given. It has to be learned across time. And that creates some problems, some opportunities for problems in some kids. There's a whole thing about sharing food, learning to share your food, learning to participate in a communal meal, which you don't eat all of one thing or you don't eat the last of any one thing. That's learning to share a critical resource, food resource among loved ones or among others in the culture or in the community. Table manners, obviously, they vary dramatically by culture, by family, by individual, and so forth. These are mediated tasks that have to be learned developmentally. So there are lots of familial, social, cultural customs that are part and parcel of what we learn as the sort of feeding practices of our people in a given time, in a given place, in a given culture. Of course, there's all those things about hunger regulation and recognition. How do you know when you're hungry? When should you eat? How do you regulate your hunger so that you're not eating all the time and overeating, but you're not self-starving? Surprisingly, these are not given. A baby waits until he or she has an empty stomach and they just wail. That's their primitive way of saying, my body needs food. But over time, we learn not to wail. We learn not to get that hungry. We learn not to cry out in public, screaming for food, but yet be able to anticipate, gosh, it's going to be noon, I ought to have something to eat. Or carry some food with us. So we learn these things across time. Same thing with hunger communication. It's not just about wailing anymore. It's about anticipating. It's about requesting. It's about asking. It's about making available. We learn communication around food. And of course, there's the whole thing in feeding, moving from profound dependence, or quite literally suckling from the breast, all the way up through bottle feeding and moving into soft foods and then into hard foods, and then learning to manipulate chopsticks or forks and knives and spoons. None of that's given. All of that's learned. We learn to become independent in our capacity to feed ourselves. These are all critical developmental tasks in feeding. Now, the truth is that because we've just joined, in some ways, the feeding disorders of infancy to the adult disorders of eating, we aren't very good at being able to anticipate the transitions in those kinds of developmental or impact of those developmental challenges across time. Conceptually, we recognize that there's a wide range of developmental tasks associated with eating, but in most cases, we don't know much about the consequences or causes associated with the failure or mastery of these. Put differently, we don't know much about how we translate from one disorder into another disorder early to a disorder late. The prevailing literature is not particularly promising or informative in that regard. So, for example, kids who have, say, pica, eating non-nutritive food substances, don't necessarily grow up into adults who are compulsive overeaters, for example, or kids who are restrictive food intake, avoidant restrictive food intake disorder kids, highly picky eaters, don't necessarily grow up to become anorectic. So longitudinal studies are just beginning to flesh out the sort of conceptual disconnects between the feeding disorders and the eating disorders. It's one of the reasons why they have always been separate specialties. Many people who specialized in the feeding disorders of infancy knew frighteningly little about the eating disorders of adolescence and adulthood. And many people who would work with anorexic or bulimic individuals knew very little about pica or very little about ruminative disorder and very little about a restrictive avoidant food intake disorder because they didn't deal with infants. They didn't deal with children. They dealt largely with anorexia and bulimia. So we're just learning to sort of connect the dots between these previously, heretofore, disconnected areas. Relationship between early feeding problems and subsequent eating disorders in adolescence and adulthood remains largely unknown. Okay, let's turn and talk about the feeding disorders themselves. What I'd like to say here is, by way of the first one, we'll talk about pica. Pica has to do with the persistent eating of non-nutritive, non-food substances for at least a 1-month period of time. Now, I want to emphasize here when I say non-nutritive, non-food substances, we're not talking about just non-nutritive substances. If we were to do that, then we would have a very substantial percentage of the population who would be diagnosed with pica, because when is the last time you had, for example, a Diet Coke? Diet Coke functionally is non-nutritive. So it does not qualify you for pica simply because it is not a non-food. It's non-nutritive, but it is a food substance. So when we're talking about a non-nutritive, non-food substance, we're talking about people who are eating paint, people who are eating chalk, people who are eating paste, people who are eating rocks, people who are eating dirt, people who are eating glass. These are widely recognized as non-nutritive. You don't get a lot of vital minerals out of eating, say, a light bulb. On the other hand, they are also, so there's not much nutritional value. They're also non-food. Yes, you can buy a light bulb in a supermarket, but people broadly understand that that aisle is not to be eaten. That is, you are not eating the dish detergent, you are not eating the Palmolive soap, you are not eating the, the antiperspirant, you are not eating the Lysol air freshener, you are not eating the light bulbs, the mops, the sponges. These are things that you are probably not going to have for lunch, you are not going to have for dinner, you're probably not going to have for breakfast. But in pica, you would. Okay, so you can see it's a conspicuous sort of challenge or disorder. Importantly, pica must be inappropriate to a developmental level. What do I mean by that? Well, kids go through levels where they eat things. Freud even called it the sort of stage of oral fixation. Kids explore their world by putting everything known to mankind in it. That if you give them something, you give them a Thomas Jefferson quarter, guess what? That is going to go into their mouth. Okay? You give them you give them this mouse right in the mouth. Anything, it could be non-nutritive, it can be non-food, but it's going to go down the hatch, okay? But that's appropriate because that's the way kids explore their world. That's why every single Happy Meal has a do not give this toy to someone beneath 3 years of age or to somebody with pica. Why? Because it will be ingested and probably it's going to be to the detriment of the child. So this is that would be appropriate to a young child. It would be inappropriate to somebody who grows up. As you move along, you can go into any kindergarten class in the United States, and you will find that there will be paste eaters. What are paste eaters? Paste eaters are, for any of you who have ever been there, you will recognize paste has a certain kind of odor, a certain kind of fragrance that for many kids, it's very appealing, it's very alluring. They open that up, it looks kind of gooey and squishy, and it looks like a soft Play-Doh. It's kind of sticky, ooh, really appealing. It's got that lovely little smell. Why not just pull out that paste thing and just take a nice big chunk of it? Well, turns out it does not taste quite as good as it smells, and kids will learn that, but they still wind up tasting it. It's irresistible. Very different from a glue sniffer. That's a different developmental phase, and that's a different disorder. It goes over into the category of substance-related disorders, and that's not going to happen in kindergarten. That's probably going to happen a few years down the road. We're in a different diagnostic category. But check out the pencils in the classroom in that kindergarten or first grade. You will see two things. Number one is you will see all those cedar pencils, those number 2 yellow pencils, will have like chomp marks all over them. Those chomp marks are not from beavers. It would appear as if that were the case. It's actually from kindergartners. They have indentations from their teeth because it turns out that that tastes really good. That texture of crunching on that cedar just is really, really, really yummy. They're not necessarily eating the entire pencil, but they are biting it, they're chewing it, and they're noticing that that eraser at the tip is remarkably seductive. That is remarkably appealing. That's very alluring. You'll see very few pencil erasers survive first grade and kindergarten classrooms because they are not because people are making lots of mistakes and erasing them and correcting their work, but because they are eating the erasers. They are eating the erasers. not because of the flavor, but because of the texture. They have that lovely, fleshy kind of texture. You can bite through it and you can feel yourself chomp through it. Yum, 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 yum. Now, by the time you get into your 20s and 30s and 40s and 50s, pencil erasers will still survive. That is, you learn not to ingest them. But that's a developmentally appropriate. You're not going to diagnose a kid who chonks on erasers or on pencils as pica when they're 4, 5, 6 years of age. It has to be inappropriate to the developmental level. It also has to not be part of a cultural practice. There are Aboriginal cultural practices, for example, that include dirt eating. And we've learned across time that a number of those practices are actually quite functional. There's actually forms of self-medication. There are cultures, for example, where they eat dirt ceremonially and ritualistically periodically, and those soils actually contain things like lithium salts that are actually sort of mood stabilizers and can be used medicinally. But if it's part of a cultural practice, you're not going to diagnose somebody as having pica. So that's an exclusion criteria. Also, if it occurs, the pica occurs in the context of another disorder, for example, a developmental disorder like an intellectual disability, a person has a very low IQ, or in the context of an obsessive compulsive disorder, or say an autistic spectrum disorder, or any kind of a medical condition, or something like pregnancy, where people can come up with the need to eat kind of sometimes quite odd things, that's not going to be a cause for diagnosis of pica. There'd be a rule out for those things. So if it occurs in the context of another disorder or a medical condition, then it is a rule out for diagnosing it as pica. Importantly, it's diagnosed as comorbid with those other conditions only if it's also serious enough to have to treat it independently. So, for example, if you had somebody with OCD and you tackled their OCD and you got it under control either through like a exposure and response prevention paradigm form of treatment or psychopharmacology, megadosages of SSRIs, for example, only if the continuation of eating that non-nutritive non-food substance continued. If it continued and it required being treated separately, then you would diagnose it as an additional comorbid disorder. Otherwise, it's just secondary to that primary condition. So that's the way it would go. And here you can see I put down here, it could be comorbid. So for example, you might have trichotillomania, which is hair pulling. Sometimes people who pull their hair out will eat that hair. But if you engage in successfully treating trichotillomania and their eating of the hair goes away, then you're not going to diagnose them as having had both. They really had trichotillomania, not primarily pica. Okay. On the other hand, if they continue eating without pulling it out, like having it hanging down and eating it, then you would. Same thing with excoriation disorder. And you can see I put the codes. These are the F codes. You'll recognize them because, again, they come from Chapter 5 of the ICD, and they constitute codes that are used in the DSM-5. All of them are mental behavioral disorders, and they are all F codes. Now, I want to just give you an example of pica. We're going to take a moment here. I want you to take a look at this. This is an example of a young lady who is experiencing pica, and she has the irresistible urge to chip off and eat and crunch masonry from inside her walls. So take a look at this, and then we'll come back and look at the next of the disorders in the category of childhood feeding and eating disorders.
My name's Patrice. I live in London and I'm addicted to eating bricks. When I eat brick, it's like a drug to a drug addict. You feel good for a while until you need it again.
You could just hear her go into town and it just crunch, crunch, crunch. You get like a little cringe feeling, and like, you know, when you hear it, you know. But obviously to Patrice, it's heaven.
I started eating brick in my late teens. I got the idea to do it from my grandma, who told me that my auntie and uncle, when they were kids, they used to dig the wall and taste it. One day I ended up trying it myself and I couldn't really stop. Throughout the day, this is about how much brick I would consume. I eat brick from my bedroom, my grandmother's bedroom, and the bathroom. This is the poster I'd use to cover up the evidence. I use different tools, screwdrivers, scissors, whatever I can to get the brick out the wall so I can eat it. So far, I have no physical problems from eating brick, and even my teeth are in good condition.
I find it very disheartening. A doctor could diagnose her now as perfectly fine, but we don't know what it could do 10, 20 years down the line.
I've eaten bricks for 12 years already, so another 12 years won't hurt.
Well, that's an example of pica. It's an unusual disorder. It's not well understood, and it was one of the disorders that was in the category of feeding disorders of infancy and early childhood. But of course, all of those disorders in the DSM-5 are combined together with the eating disorders into a common single category called feeding and eating disorders. Well, let's turn from pica then and talk about the second of those feeding and eating disorders, and that's rumination disorder. Well, what is rumination disorder? Rumination disorder is a kid who repeatedly regurgitates food for at least a 1-month period of time. Now, what do I mean by regurgitation? What I mean is the child typically will chew the food and then swallow it and then bring it back up, typically into the mouth, sometimes spitting it out, but more often re-chewing it and swallowing it again, much like a cow does with its cud. You chew, you swallow, and then you bring it back up and you re-masticate. Importantly, this rumination disorder can't be attributable to any kind of an associated gastrointestinal disorder. So, for example, if you have an acid reflux disorder and you bring food back up because you have sort of a esophageal problem with your peristaltic waves, they reverse and the food comes back up, that's a gastrointestinal condition. So that would not be an example of a rumination disorder. It's also important to keep in mind that rumination disorder cannot occur exclusively in the context of another eating or feeding disorder. It can't occur during anorexia or bulimia or binge eating disorder, or one we'll talk about in just a minute, the avoidant restrictive food intake disorder. So it really needs to be a sufficiently standalone disorder to be discernibly different, and then and only then does it count as an independent rumination disorder. Otherwise, you would just treat the other eating disorders and see whether that one feature, bringing the food back up, would dissipate because it's secondary to another eating disorder. If it does occur with other disorders, it would only get diagnosed if it was sufficiently severe to warrant separate attention. You treat the anorexia and the person is still doing the rumination. You treat the bulimia and the person is still chewing, chewing, bringing up and re-swallowing the food. So only if it would persist beyond the successful treatment of another eating disorder, if it happens to co-occur or be comorbid with another eating disorder. It's also worth mentioning that rumination disorder is joined by the third of what was the feeding disorders of infancy and childhood, and that's the avoidant restrictive food intake disorder. Now, this disorder comes into the DSM-5 with this brand new title. Before, in the previous DSM-3, 3R, 4, and 4TR, it was called Feeding Disorder of Infancy or Early Childhood. But you can see the name Avoidant Restrictive Food Intake Disorder is far more descriptive than Feeding Disorder of Infancy or Early Childhood, which is really not very descriptive and quite nebulous. The title says it all. These kids are avoidant of most forms of food. They have a very restrictive selection of foods that they eat. Maybe they will eat only French fries or mashed potatoes. Maybe they'll eat only a cheese pizza, nothing else on it, please. Maybe they will eat peaches, or maybe they will eat grapes, but they won't eat all of that and they won't eat anything else. So severe is the avoidant restrictive food intake disorder that it oftentimes requires nutritional supplements because the kid otherwise will be at risk either for nutritional starvation, just not taking in enough calories, or more commonly still, dietary challenges, scurvy, rickets, just not having the proper balance of nutrition and not having nutrients that are sufficient to sustain the body and health. Importantly, in the avoidant restrictive food intake disorder, the feeding disturbance has to be is manifested by persistent failure to meet appropriate nutritional needs, and is associated with one or more of the following things. They don't eat many things, they don't eat much, and so they have significant weight loss. Number two, they have a significant nutritional deficiency. So again, they're at risk for scurvy or rickets or vitamin D deficiencies or a wide variety of things. Three, a dependence on feeding tubes or supplements. And then four, marked interference with psychosocial function. And of course, these commonly co-occur. It wouldn't be at all uncommon to have a child have 2 or 3 of these symptoms who is suffering from an avoidant restrictive food intake disorder. You can imagine if you're only able to eat or only interested or only willing to eat 2 or 3 things, for example, how that might influence psychosocial functioning. And by the time the kid gets into school, they're being made fun of, they're not participating in the cafeteria meals like everyone else, and they're kind of marginalized. And then you get into the secondary kinds of hazing and bullying and things that begin to wreak havoc on the child's sense of self-esteem as well. Importantly, there are rule-outs with avoidant restrictive food intake disorder, just as with pica. So, for example, avoidant restrictive food intake disorder cannot be better explained by something like the simple lack of available foods. If the person is losing weight and only eating a restricted diet because there's only limited amount available, the family is growing corn and corn is all they have to eat. Well, obviously that's not an avoidant restrictive food intake disorder. That's an insufficiency of a food source. It also can't be a cultural practice. We saw that under pica. You have some cultures, for example, Aboriginal cultures that will eat dirt or put stones in their mouths. That's a rule out. That would not be pica, that would be a cultural practice. And the same thing is true here. Some religions, for example, would assiduously avoid certain kinds of food and restrict their diets. That would not be an example of an avoidant restrictive food intake disorder because it's culturally appropriate or it's religiously sanctioned. Importantly, just as with pica, you would not diagnose an avoidant restrictive food intake disorder if it occurred in the context of anorexia, bulimia, or another body image distortion. If it's secondary to those other conditions, you would really treat those other conditions and then see whether or not the avoidant restrictive food intake disorder persisted. So importantly, it's not attributable to other concurrent medical conditions or mental disorders. So for example, if the person has ulcerative colitis and they are very sensitive to certain kinds of rough foods, hard foods, crunchy foods, or sensitive to temperatures, you might have a gastrointestinal disorder that accounts for why it is the person is only able or comfortable to eat certain kinds of limited foods, maybe soups or maybe creamy, warm, soft foods. So again, that would not be an avoidant restrictive food intake disorder. That would be another medical condition. So there's a rule out for concurrent other medical or mental disorders. Well, let's take a look for just a second as we transition from what was before in DSM-3, 3R, 4, and 4TR, the feeding disorders of infancy and childhood, to the eating disorders like anorexia and bulimia. Let's just pause for a second. I just want to highlight that because these two different classes of disorder are now combined together into this combined group of feeding and eating disorders, it really calls into attention the potential relationship between those two different types of disorders that used to be in very different parts of the diagnostic manual. And I just want to call your attention to a single study. This was a study of 442 children that had feeding problems. And they classified these kids as having feeding disorders of two broad types. One group consisted of those who just had little interest in food or they had problems with textures. They were poor eaters. These were people who didn't like slimy foods, or they didn't like soft foods, or they didn't like crunchy foods, or they didn't like hot foods, or they didn't like cold foods. They were kind of restrictive, avoidant food intake disorder kids. They were poor eaters, picky eaters, finicky eaters. The second group was a group who had emotional reactions to food. They were very afraid of, not disinterested in, but frightened by food. Almost like a food phobia. So for example, they wouldn't eat peanut butter because they feared that they would suffocate. Their tongue would get stuck to the roof of their mouth and they would just sort of suffocate, aspirate in the peanut butter. So they had food phobias or fears. Now, interestingly, what happened is they took these kids and they followed them across time for about a 10-year period of time to see what kinds of eating disorders they matured into, or what they call converted into, as they grew up. And what they found is really no predictable relationships. So you had these demonstrable disorders of eating in childhood, but the kids sort of largely grew out of them, or just grew into not particularly interested in food, or gradually expanding their food interests but not having a full palate of foods. But it's not as if they converted into adult forms of eating disorder. It's not as if these two clusters of developmentally related feeding disorders converted into anorexia or bulimia or binge eating disorder or any other predictable pattern of adulthood. One of the hopes in combining together the feeding disorders and the eating disorders in the DSM-5 is that it would allow us to focus more research attention on the relationship between these two different classes of disorders. So we've seen that in the current category of feeding and eating disorders, the feeding disorders are pica, rumination, and avoidant food, restrictive food intake disorder, which we've taken a look at. And the eating disorders now are anorexia, bulimia, and binge eating disorder. So let's turn our attention to those disorders. Anorexia consists of the refusal to maintain body weight at or above the normal weight for age and height. And here I'm putting in red a change in the criteria that occurred in the DSM-5. It used to be in DSM-3, 3R, 4, and 4TR, they had a stipulation, was really just an EG, that the person weighed less than 85% of their anticipated expected normal body weight. But the problem with that is that even though that criteria was in there as an example, not as a criteria per se, but just as an illustration, people saw that 85% figure and they sort of used it more as a rigid criteria. And what would happen is a woman, say, would come in and she would be, say, 82% of her body weight. Then they would go through a refeeding program and she would get up to, say, 90% of her body weight. Well, now she no longer would satisfy that criteria, so they would then have to change the diagnosis from anorexia to something like, back then, an eating disorder not otherwise specified. Now it would be something like an other specified or unspecified eating disorder. And then, of course, what would happen is she'd self-starve again and get back down to 81 or 82%. Then she'd be back diagnosed as anorexia, refeed, get up to 90, 95%, back over into an other specified eating disorder. So you just had this pendulum swing back and forth that made absolutely no sense, because she was anorectic from the beginning, she's anorectic at the end, she was anorectic in between those two times. So the diagnostic criteria with that 85% criteria was misleading. So they literally have just removed it. What's in red here, that is the EG less than 85% of body weight, has now been removed. The second criteria is the person has an intense fear of gaining weight or becoming fat, and this is an addition in the DSM-5, or persistent behavior that simply interferes with weight gain. This change in the DSM-5 was made, the addition of this persistent behavior that interferes with weight gain, that was included because the first part of that criteria, intense fear of gaining weight or becoming fat, seemed to be more peculiarly North American, and particularly in the United States. It has more to do with the fear of looking fat. It has to do with a vanity issue. I'm afraid of getting fat, looking bad, losing my friends, or whatever. Whereas elsewhere in the world, it seemed like there are lots of instances, more commonly, not where the person feared getting fat per se, but they simply didn't engage in the eating behavior that allowed them to maintain or gain weight. So there are no attributions about fear or panic or any evaluation or any vanity. They simply don't engage in the behavior that allows them to maintain or gain weight. The third criterion is a disturbance in the way in which the body weight or shape is experienced. It's a body image distortion and undue influence of body weight or shape on self-evaluation, or a denial of the seriousness of low body weight. And of course, you see this all the time in anorexia. You see an individual who is absolutely as thin as a broomstick, but he or she sees themselves as fat, overly weight, having paunch, is flabby. And feels like they need to lose just a few more pounds. But in truth, their BMI may be down at 14 or 15, and they are medically compromised and really in early stages of starvation. So it's a disturbance in body image or shape. You feel like you're heavy, you feel like you're big, you feel like you're fat, and objectively you are anything but. The fourth criteria is amenorrhea. Amenorrhea is the absence of at least 3 consecutive menstrual cycles. And this has been a criteria in the DSM from the very beginning, from actually the DSM-1, when it was first published in 1952, included only one eating disorder. It was anorexia. And this criteria was in there. So it's been in there a long, long, long time. It is dropped in the DSM-5. Amenorrhea, the absence of at least 3 consecutive menstrual cycles, is no longer included in the criteria set at all. It's not a criteria for the diagnosis of anorexia. Why is that? Well, because the requirement obviously was an irrelevant criteria when it came to anorexia for men and for premenstrual women, as well as post-menopausal females. So there are 3 large classes of people that it couldn't apply to at all, would be a meaningless criteria. Also, women using birth control pills can artificially not have 3 or more consecutive menstrual cycles. And the data, when they looked at it closely, indicate that females who menstruate but otherwise meet the criteria for anorexia are in fact clinically very similar to non-menstruating females with anorexia. So it was a difference that didn't make a difference. It was a criteria that didn't really mean much. Plus, the truth of the matter is this: if you lose enough body fat, go back and look at criteria number 1. If you lose enough body weight and enough body fat, you're going to lose your period. So really, amenorrhea was secondary to the primary number 1 criteria anyway. It just doesn't add anything new, it doesn't add anything meaningful, and it doesn't enhance either the reliability or the validity of the diagnosis. So it is, after all these years, long last dropped. Let's turn and take a look at the second then of these eating disorders within the combined category of feeding and eating disorders, and that's bulimia. Bulimia was added in the DSM-3. In bulimia, the person feels incapable of controlling the urge to binge, and they consume a great deal more food than a person ordinarily would consume at one sitting. So they have an urge to gorge, an urge to binge. They can't contain that, they can't constrain that, they can't reframe, and they literally just sort of gorge themselves, oftentimes on highly fatty foods. Twinkies, bread, ice cream, pizzas, cupcakes, a lot of sweet, a lot of starches, oftentimes 5, 10, 15, even 20,000 calories in a single setting. So it's a high volume, rapidly eating kind of binge. They also engage in some kind of purging or what's called compensatory behaviors. Compensatory behaviors are compensating for the caloric intake with some kind of caloric expenditure. That might be through vomiting, so I gorge, I eat the 24 Twinkies, and then I go in and I do self-induced vomiting. I either put my fingers down my throat, or I take Epicac to induce vomiting, or I've just learned to control. I get so stuffed, I get so full, I can just will myself to heave. Or maybe I'll take laxatives, that's another compensatory mechanism, or diuretics, or excessive exercising. So those are all examples of compensatory behavior to sort of compensate for the binge. So the purge compensates for the binge. Binge-purge cycle is the telltale feature, the hallmark feature of bulimia or bulimia nervosa. Importantly, the person in the DSM-5 needs to engage in this behavior binge-purge cycle at least once per week for 3 months. Now, this is a change because in previous editions of the DSM, the individual had to engage in this binge-purge cycle at least twice per week for a 3-month period of time. So they've relaxed that criteria down to at least once, from twice to once per week. The truth of the matter is most people who are binging and purging are actually doing that more commonly than once a week anyway. They're doing it 2, 3, 4 times a week, and sometimes they'll get up to be doing it 2, 3, 4 times a day. So by reducing the criteria from twice a week to once a week, it's not as if the prevalence rate is going to skyrocket or double in the prevalence of bulimia. They did reduce it to once per week on the rationale that in introducing a new disorder that we're going to turn and look at in just a second, binge eating disorder, it also requires that the person engages in binging behavior at least once per week. They didn't want to keep bulimia at twice per week if binge eating disorder was going to come in at once a week, because it would make it seem it would be inconsistent. You would make it seem like it's a more severe disorder or be held to, if you will, sort of a higher standard. So they reduced it down to once a week to make it match binge eating disorder, as we will see. The self-evaluation is unduly influenced by body shape and weight, much as it is in anorexia. And so the person has a body image distortion, and they feel badly about, unrealistically badly about how they look. And weight being is a very important feature to them. Unduly so. Self-value is predicated on appearance excessively. And importantly, the individual does not meet the criteria for anorexia. If they meet the criteria for anorexia, even if you are binging and purging, you go over into an anorectic category, not into bulimia. So anorexia is a rule out for bulimia. They do ask that you engage in rating for severity, and the severity is mild, moderate, severe, or extreme. In the case of bulimia, mild is 1 to 3 episodes per week. Now, I know it may not seem mild to you if you are self-induced vomiting 3 times a week. That seems to get pretty severe, but that's actually a mild instance. Moderate is 4 to 7 episodes per week. So you'd be doing binge purging almost up to daily. Severe is 8 to 13 episodes per week, and then extreme is 14 or more per week. You'd be binging and purging at least twice a day on average. So you can see that it can get pretty severe, pretty extreme. Oftentimes these people feel guilty, they feel badly, they feel ostracized, they feel closeted. They hide this behavior from people as best they can, and oftentimes do that quite successfully for many weeks, months, or even years. But inside feeling badly, knowing something's wrong, and not wanting people to discover for fear they would think even worse of them still. I mentioned binge eating disorder, and so let's turn and talk about that. Binge eating disorder is the newest addition in DSM-5. It comes in for the first time. It was in the conditions for further study in the DSM-4 and DSM-4 TR. So it's been hanging out there in limbo, in purgatory, waiting for salvation, waiting to be rescued, waiting to be brought through the pearly gates for nearly 20 years. DSM-5 finally brings it in. It is now elevated to the main body of the manual from the appendix, conditions for further study in the DSM-4. What's the rationale for its inclusion? Well, this is quite literally a quote from the DSM-5. It says, binge eating disorder is highly recognized in the clinical literature as a valid and clinically useful diagnosis. Further, a significant portion of cases of DSM-4's eating disorder not otherwise specified, what used to be called EDNOS, would meet the criteria for binge eating disorder. Therefore, by including binge eating disorder, this should reduce the use of the unspecified eating and feeding disorder designation in the DSM-5. So they're saying, gosh, it's been around a long time, it's about time we recognize it, and by doing that, we're actually going to enhance the specificity of diagnoses, because a fair percentage of those things that didn't get diagnosed before, that weren't anorexia and weren't bulimia, they really were versions of binge eating disorder, and now they don't have to go under that unspecified category anymore. They can have their own clear diagnosis. What is a binge eating disorder? Well, it's defined in this way. Recurrent binge eating is characterized by eating in a discrete period of time, for example, within a 2-hour period, an amount of food that's definitely larger than what most people would eat in a similar period of time under similar circumstances. And then B, the episodes are associated with at least 3 of the following things. 1, the person is eating more rapidly than normal. So, you ordinarily would eat a sandwich, take a bite, put it down, chew it, swallow it, so forth. Okay? It might take you 5 or 10 or 15 minutes to eat a sandwich. Well, in a binge, the person might just shove the entire sandwich in and just keep chewing as they're swallowing it. They're literally sort of gorging. They're taking the Twinkie and just stuffing it down in their mouth. They're taking pancakes, folding them up, and just shoving them in. So it's really a gorging, almost a frenzy. Many people, in the context of a binge, will talk about how they're almost dissociated or frenzied. They just lose touch with reality, and they're just possessed in a way. So eating much more rapidly than normal, eating until feeling uncomfortably full, sometimes eating until they're so stuffed they can't eat anymore, just like stuffing it down the gullet, and sort of ramming it in and just feeling bloated big distended belly where you just gorged on everything that you could possibly. I mean, imagine you eat, say, 3 loaves of bread, a couple of large pizzas. You then go into the ice cream and you choose not to eat just a quart or a gallon, but you're eating 2 gallons. And then you're finishing it off with a box of 12 Twinkies. Now we're talking about a full belly. It is a full belly. So the person sometimes will eat until they just are almost like, you know, it's like some animals. Some animals you can free feed and some you cannot. Free feed means you give them all the food and they eat a little bit as they want the food, and others you have to do controlled feeding because they will just gorge until they will die of bloat. And so what happens is these individuals get to the point of just being abnormally full and can't cram anything more in. They're also eating large amounts of food when they're not hungry. It's not hunger-borne food ingestion. It's really an emotional issue to try to sort of almost like a compulsion, like a compulsive urge. Oftentimes, more often than not, by far, they eat alone due to the embarrassment that they have about the quantity of food they're going to eat. It's very common that they will take food and they will kind of they'll hoard it, and they'll hide it up in their rooms, or they'll hide it in places where people don't have access to it. They'll store it up and then they'll secretly go in there when nobody's noticing, you know, shut the door, turn off the light, and just gorge. So they recognize that it's unsavory, it's untoward, it's not quote unquote normal, and they're embarrassed about it. So they do it in privacy. And then of course, they feel disgusted with themselves, very depressed, very guilty, very angry, a lot of self-loathing. They can't control it, but they detest themselves for doing it. Now, importantly, in binge eating disorder, there is no compensatory activity. So unlike bulimia, where you're engaging in excessive exercise, diuretic use, laxative use, or going in and purging, here you're not doing that at all. You're binging in the absence of purging. So that's a significant issue because, of course, if you continue to binge and you engage in no compensatory behavior, all the caloric intake is coming in, but none of it's going out. So the tendency, unlike bulimia, the tendency is for people with binge eating disorder to become progressively more overweight, to the point even of morbid obesity. There is marked distress regarding the binge. I mentioned feeling guilty, feeling self-loathing, feeling really badly about themselves, but unable to control themselves. Importantly, the person has to engage in this behavior at least once a week for a 3-month period of time. If you remember, this is what I was saying about bulimia. Bulimia used to be a minimum of 2 times a week for 3 months, but because binge eating disorder was coming in at once a week on average for 3 months, they didn't want to introduce a discrepancy between the two, so they brought bulimia down to once a week so that both bulimia and binge eating, the person engages in the binge purge in bulimia, binge alone in binge eating disorder at least once a week for a 3-month period of time. And so they're consistent in that regard. Importantly, with binge eating disorder, it's not associated with bulimia or with anorexia. If you have an anorectic who periodically binges and just loses control, self-starves to the point of then just being driven into gorge on food, that's still anorexia. That's not going to be called a binge eating disorder. And similarly, if the person's binging but they're also purging, then that's bulimia, bulimia nervosa, and not binge eating disorder. So it needs to be a standalone binge in the absence of a purge to qualify for a binge eating disorder. Let me mention that there are, of course, in the DSM-5, the other specified and unspecified feeding or eating disorders. The other specified could be a variety of things. What does other specified look like? Well, you might have an atypical anorexia, for example. That could be an other specified eating disorder. You might have a low frequency or limited duration bulimia. So maybe the person is not on average once a week engaging in a binge purge cycle, but maybe what happens is during periods of high stress, during finals periods, during when they go home to their parents and their family, then they tend to binge and purge. Or maybe they don't binge and purge when they go home, but they do when they come back to college and are in the dormitory. So it would be a low frequency or limited circumstance or limited duration bulimia. So it's like close but not no cigar. It's a subclinical. Now, it doesn't meet all the criteria for bulimia, but it's clearly disturbed eating, and so it probably warrants being diagnosed and treated. So you might call that an other specified eating disorder, low frequency bulimia. Same thing with binge eating disorder. You might have a low frequency or limited duration. You might have somebody who's engaging in a purging disorder, but they never really binge. Well, if they're not binging, it's not a binge eating disorder. If they're not binging, it can't be a bulimic disorder that requires binging and purging. So maybe they're just engaging in purging. So you would just say other specified eating disorder slash or dash purging disorder. Those would be examples of other specified. Unspecified means you really don't know. You can see the person has weight disturbance. You can see that they have really unusual eating or feeding behavior or attitudes or thoughts. Maybe they have chronic dietary consciousness. They have odd ideas about what are good foods to eat, but you can't put your finger on what exactly it is. So you might just say eating disorder unspecified. It might be sort of limbo, and you need to find out more, and you need to work with the person for a longer period of time to sort out what it is. Now, I want to say something about one group of disorders that is not officially sanctioned or recognized within the DSM-5, but it does represent an example of something that you could put in as a eating disorder other specified, and that's a compulsive overeater or a food addict. Compulsive overeaters or food addicts. You can see a compulsive overeater, you can characterize it as an addiction to food. A person engages in frequent, uncontrolled eating or binging, but very commonly they're also just sort of continuously grazing. These people are thinking about food, they're ruminating about food, they're anticipating meal preparation and ingestion and digestion all the time. So their lives are sort of occupied by food-related thoughts and behaviors. Now, importantly, there are no compensatory behaviors. The person's eating a lot, eating and grazing continuously, binging periodically, but there is no compensatory behavior. And in that context, if you're eating continuously and binging occasionally, then you are going to gain weight. And so these people invariably do become obese. They do become obese. Importantly, one thing that discriminates them from the other eating disorders is in the other eating disorders, there's a deep ambivalence about food. There's a love-hate relationship with food. But with compulsive overeaters, the attitude toward food is primarily positive. It's primarily favorable. I like food. I enjoy food. I'm a gourmand. I like to eat. I love to eat. I love to prepare food. I love to cook. I love to clean up. I like, to have people over. I just like all kinds of food. I like fatty foods. I like rich foods. I like creamy foods. So food has a positive valence. Of course, the person can feel badly about their weight, about their appearance, be concerned about their health, but the notion is that the overall attitude toward food is not an ambivalent one so much as it is a favorable one. And that's what I'm mentioning here, generally has a positive attitude toward food. But let me mention something here that that's not lost on us in this day and age. Here I'm just going to show you obesity trends in U.S. adults. Now, you'll see there are three sort of pictures here that reflect three different time periods. Here you can see in the United States sort of color-coded for individuals of different weight categories in 1990. And if you notice here, and look down at the legend, you'll see the white states, there's just no data on. The light blue states are states in which fewer than 10% of the residents of that state are obese. Obese is defined by a body mass index of greater than 30, which is about more or less 30 pounds overweight for, say, a person who's 5'4". So this would be substantial overweight, not quite morbid obesity, but it's substantially overweight. So you can see there's about, whatever, a third of the country is less than 10% of the population. About a third of the states, less than 10% of the population is substantially overweight, BMIs over 30. And then you can see the second color is this kind of mid-range blue, and the mid-range blue is the percentage of the population is between 10 and 14% who are substantially overweight. Now, and that's pretty much the map. It's the light blue and the second blue color. Now, fast forward from 1990 over to 2000. Now you'll see a couple of things. Number one, the light blue is completely gone. There are no states in which fewer than 10% of the people are obese. They just don't exist. There's only one state in which 10 to 14% of the population is substantially overweight or obese. Now we've introduced a new color, 15 to 19% of the population, and you can see that about half the United States now is 15. The states, about half the states have 15 to 19% of their population being substantially overweight, obese, and the other half now have 20 to 24% of the population being obese. Now take that map and fast forward another 10 years, and here we find ourselves in 2010, and you can see that we've introduced two more colors. Now there's no blue whatsoever. There's no light blue, there's no medium blue, and there's no dark blue. Now there's this sort of beige color, and that represents states in which 20 to 24% of the population is obese. And then you have the red color, and this is 25 to 29% of the population in those states is obese. And now you have this other new category, the dark red, and that's states in which over 30% of the population, nearly a third of the members, citizens of those states, are morbidly obese or obese. So you can see in sort of time-lapse fashion over a period of time the dramatic shift in weight and increase in obesity in the United States. It is the case that right now about 1/3 of all adults in the United States are medically obese. So I want to just mention a couple of things about that in relation to compulsive overeating. First of all, I want to underscore that virtually all compulsive overeaters wind up being obese. They do, because they're eating a lot, they're eating continuously, and they're not engaging in compensatory activity. But that does not mean that all obese people are compulsive overeaters. You can come to obesity through a lot of ways. You can have a genetic predisposition toward obesity. You can come to it through medical conditions. You can come through it through taking medications. So there are a lot of ways that you can gain substantial weight and become obese that don't have to do with eating. So when you see somebody who's obese, you cannot assume that they are necessarily compulsive overeaters, because that's simply not the case. I will say that the overeating disorder was considered for possible inclusion in DSM-4. It was considered again in DSM-5. Among the reasons for not adopting it was the fact that it would have automatically brought about 1/3 of the adult population in the U.S. into potential consideration for a mental illness, that is, a compulsive overeater. Not all of them would qualify, but it would bring them in for possible consideration. And the downstream implications on that for the healthcare system and the costs would have been very, very, very substantial, and so they decided to pause and not do that. DSM-5 followed the same rationale as DSM-4 and did not include compulsive overeating. However, if you see somebody in clinical practice and you see a pattern of compulsive overeating or a food addiction, you can diagnose it. You would just diagnose it as an eating disorder, other specified - compulsive overeating or food addiction. Completely reasonable to do. What the DSM-4 says in its source book, its authoritative source book that reviews all of the evidence and provides the opinions of the individuals who made the decision not to include it formally. What they said was this, and the DSM-5 reasserted it: the evidence reviewed was not sufficient to warrant the addition of a new category of pathological overeating, which was one of the names they were going to call it. However, the available studies clearly raise the possibility that there are individuals who suffer from a non-bulimic overeating syndrome that is not covered by our current classification system. Further research is needed to identify the features of this putative syndrome. So you can see they're leaving the door open for future consideration. Now let me just say that we've talked about the set of different disorders. We've talked about pica, we've talked about the rumination disorder, we talked about avoidant restrictive food intake disorder, we talked about bulimia and anorexia and binge eating disorder and compulsive overeating. But I want to mention that despite these normative trends, and these are of course normative classifications, the criteria fit are used to diagnose in all individuals in the same way, it's nonetheless the case that there's a lot of ipsative variation in the presentation of eating disorders, and some of those variations occur according to culture. And I just want to underscore this because eating disorders are not randomly distributed across different cultural groups or geographic regions. I'm just going to show you a couple of slides here to illustrate that. This is an example, a slide that comes from NIH, and it's just looking at samples of whites and blacks. These are actually, this is the overall prevalence rates, white and black among women. And you can see that for anorexia, for bulimia, and for binge eating disorder, it is substantially more prevalent among white women than among black women. Substantially higher prevalence, and differentially so. So anorexia in black women is extraordinarily rare. You've got 1.5% of white women anorectic. It's really, really, really uncommon to see a black woman who is anorectic. Now, you do see a higher prevalence rate for binge eating disorder, and blacks have a greater prevalence in that particular kind of disorder. But across all different types of eating disorder, it afflicts whites more than blacks. So they talk about culture as maybe a potential risk factor or a protection factor in the case of being African American. But I also want to mention that even when individuals have a common disorder, say they have bulimia, say they have a compulsive overeating, or they have anorexia, different racial groups do not always present with the same symptom sets. So I'm going to give you an example of a study that was done by Pike et al. In 2001, where they compared matched groups of black and white women who were diagnosed with binge eating disorders to community samples of black and white women who did not have binge eating disorders. And what they did is they looked at the level of sort of sub features or qualities of problematic eating. They looked at levels of eating concern, the extent to which they were concerned about what they were eating, dietary restraint, that's individuals who are trying to keep from eating, they have a chronic dietary consciousness, and they're trying to restrict their food intake and diet, and then also shape concern and weight concern. So these are a set of different kinds of sort of subclinical attitudes toward food, if you will. And we're just going to compare the blacks and black sample, white sample, who do and do not have binge eating disorder along those 1, 2, 3, 4 sets of eating related dimensions. So for example, you can see in the samples both of the black women and the white women who do not have a binge eating disorder, you can see the prevalence of eating concern, dietary restraint, shape concern, and weight concern are all quite low, as you would expect. They don't have disordered eating. They have some, there's 1% who are concerned about their weight. Some feel a little bit too curvy or rounded, or their hips are too large. So there is some level of sort of cognition along those 4 different dimensions, but it's really very minimal, certainly compared to the binge eating disorder, which would be the black and the dark gray. So you can see eating concern, in every single instance, whether it's eating concern, dietary restraint, shape concern, or weight concern, the white sample of binge eating disorder women is higher than the black sample. So there's variability across those 4 different dimensions, but in every single instance, the whites outdistance the blacks. So the patterns and robustness of symptomatology can vary by race. So I just want to put that in there as a cautionary note, because you do see variability by gender, you do see variability by racial group or culture, and it's important to take that into consideration when you're doing diagnosis. Well, let me just say a few concluding words about a transdiagnostic approach, and then we'll just sort of sum up. The DSM-5 is, as the DSM has always been, a categorical system. That is, you either have a disorder or you don't. You either meet the criteria for it or you don't. So it is a nominal system. It is a categorical system. You have categories and you pigeonhole people into those categories according to whether they have sufficient symptomatology to warrant a diagnosis. That's very different than a dimensional form of analysis. And I want to mention to you that both the eating disorder and the personality disorders groups have been very seriously under consideration for dimensionalizing rather than retaining a categorical approach. Bob Spitzer, who was the task force chair of the DSM-3 and 3R, noted all the problems with the current categorical, that is, you either have it or you don't have it, it's either present or it's not a present approach to the classification of personality disorders. They've long recognized, has long been recognized as problematic by clinicians and researchers. In the case of personality disorders, for example, there are 10 recognized categories of personality disorders, but the most commonly conferred diagnosis in personality disorders is in truth PD-NOS, personality disorder not otherwise specified. In other words, there are more cases that don't fit the rule than do fit the rule. The same is true with eating disorders. Until the DSM-5 sanctioned the binge eating disorder, it was the case that between 2/3 and 3/4 of all eating disorders were EDNOS, eating disorder not otherwise specified. They weren't anorectic and they weren't bulimic, they were something else. Well, it's a problem when you have a categorical system in which fewer things fit those categories than don't fit the categories. So those two categories, the personality disorders and eating disorders, were under strong consideration, have been for years, to be put on dimensions, which we'll talk about in just a second, rather than being categorical. As with personality disorders, as I mentioned, within eating disorders, there are fewer instances that fit the category than fall in between the cracks. A transdiagnostic approach, or is a dimensional approach rather than a categorical one, and what it does is it would identify a series of dimensions. Say in eating, it might be something like over-controlled versus under-controlled. So, for example, an anorectic might be over-controlled, a compulsive overeater might be under-controlled. Maybe introverted and extroverted, maybe feeling positive about food versus negative about food. Maybe feeling irresistible urges versus lack of awareness of hunger signals. The notion is you'd have a series of these kinds of dimensions, maybe 3, 4, 5, 10, whatever it may be, and then every single individual could be fit in psychological space along those dimensions. Huge advantages of a dimensional approach over a categorical approach. Number one is nobody slips through the cracks. Everybody fits somewhere in dimensional space, and they occupy a particular place in the coordinates that are defined by the various dimensions. Each person is one dot along those various dimensions in space. And importantly, no two people would fall in exactly the same place. Very different than a categorical approach. A categorical approach assumes uniformity. If you reach the criteria, then you kind of assume that if you're bulimic, you're bulimic, and there's an assumption of similarity. The truth of the matter is no two bulimics are exactly alike. A dimensional approach allows you to characterize and respect that individual variability. The fact that people are like snowflakes or fingerprints, no two are the same. Categorical approach obscures that, eclipses that, but a dimensional approach would actually still preserve that. Maps on very much to the way we experience people, that everyone is different. But the truth of the matter is the DSM is a fundamentally conservative system, and they have tried for 3 iterations, 4 now, DSM-3, 3R, 4, and 4TR. They've been unable to mount a revision either of the eating disorders or the personality disorders along dimensional analysis. This last time in DSM-5, they came close to dimensionalizing the personality disorders. They came up with a hybrid system, half dimensional and half categorical. They would use dimensions of personality to get you close to a diagnosis, and then ultimately those dimensions would lead to a categorical specification. However, ultimately the DSM rejected that hybrid model, and as a concession to the personality disorders work group, they put it in the conditions, they put it in the appendix under emerging models and measures. In fact, it is that dimensional approach to the diagnosis of personality disorders is the emerging model in that section 3, emerging models and measures. It's an unofficial section. It's there for future research. Maybe it will rear its head again when DSM DSM-6 rolls around. So it's there as a kind of space saver. It's there maybe as a harbinger of things to come. But a dimensionalization of a categorical system has been a long time in the making, and it has not yet come to fruition in the DSM-5. DSM is a fundamentally conservative system, and it remains a categorical system in this, the eating and feeding disorders, as with all other areas. Okay, last thing I'll mention, just by way of summary of things we've talked a bit about. We talked about the area of eating disorders has received very significant revision in the DSM-5. It combines together the old feeding disorders of infancy and early childhood and the eating disorders of adolescence and adulthood, and now it's just one common category. It's called feeding and eating disorders. We've seen that new disorders have been added in. Binge eating disorder is an example of a new disorder added in. Compulsive eating disorder was considered but not included, and there have been some criteriological changes and revisions like we talked about in anorexia and in bulimia. It's clearly the case that the revisions of the current criteria are going to continue to receive attention as we move forward to see how well they perform. Anytime there's a change in the criteria, it could potentially affect prevalence rates, and we want to be sure that the criteria are performing effectively. It may be because we've combined together the feeding and eating disorders, maybe it will give greater focus to research on developmental considerations. Maybe developmental considerations are going to figure a bit more prominently as we try to sort of bridge together the feeding and the eating disorders and try to understand the relationship between those categories that heretofore were always separated. And finally, I'll just say that the categorical system of diagnosis is sure to be evaluated and reevaluated again in the future in relation to transdiagnostic or dimensional forms of diagnosis. Well, this is a good place for us to stop, giving you a good sense at least of the overall kinds of changes in the criteria and in the disorders that typify this new category in the DSM-5 called the feeding and eating disorders.